I'm Dr. Patta Radhakrishna. I'm the head of Department of Surgical Gastroenterology and Advanced Laparoscopic Surgery at SRM Institute of Medical Sciences, Vadapalani, Chennai. This patient, Mrs. Shyamala, was brought to me by her friend about a year ago with recurrent attacks of upper abdominal pain, and ultrasound scan done elsewhere had shown evidence of gallstones. And then when I saw her, took history, examined her and looked through her investigations, and we confirmed her gallstones by a repeat ultrasound scan and the liver function test here, and advised her surgery. I did take some time in showing her a video presentation of all about gallstones as to how they can cause problems and how we need to treat them, and then I said that she would require removal of the gallbladder by a laparoscopic method, and I also told her that she needs to stay in the hospital just for 6 hours, come in the morning, get a gallbladder removed and go back in the afternoon. And then I also answered three common questions generally asked. One is, can't you take just the stones off, and why do you remove the gallbladder? Then for that my answer was that the non-functioning gallbladder is the cause for gallstones. So if stones are removed, they're going to form again, so it's necessary to remove the gallbladder. And the second question is, if gallbladder is removed, what will happen to the digestion? I said digestion will improve. Actually at the present moment the gallbladder is not contributing anything to digestion. And the third most important question that she asked is, what can I eat and what can't I eat after surgery? I said, you can eat everything. There's no any such restriction. And after she was convinced, she was planning to get operated, but I couldn't see her for another 1 year, and she came back recently again, and then this time we took her up for surgery, and again I reiterated the reasons for removal of gallbladder and also talked about how comfortable it will be. Then I sent her to Dr. Pooja, consultant anesthesiologist who specializes in daycare anesthesia, especially she is one of the specialists in the field of TAB block, transverse abdominal spleen block, which will be explained to her in detail and then taken up for surgery.
I am Dr. Pooja Bagdi Agrawal, anesthesiologist at SIMS Hospitals. So we have a patient today who I am going to see, and she is scheduled for a ambulatory laparoscopic cholecystectomy tomorrow. The question is ambulatory laparoscopic cholecystectomy possible, or in layman words, a daycare surgery of the gallbladder possible? It is being done in the Western world day in and day out. It is the standard of care there. In India, we want to popularize this concept because it's safe and the patients will also be happy. So how is it possible? The anesthesiologist plays an important role in daycare surgeries. All patients are most worried about pain. Will I be okay, doctor, if I go home? Will I have pain? Will I have any nausea? Will I have vomiting? Will I be able to walk? Will I need help? Will I be able to manage by myself? The answer to all these questions are yes. You will have no pain. You will be able to walk. You will have no nausea. You will have no vomiting. So this has been made possible by some anesthesia techniques. So along with the balanced general anesthesia, we do an ultrasound guided bilateral dual tab block. When the patient is under general anesthesia, with the help of ultrasound, we give them a block that blocks the nerves that supply the abdominal wall. So when the patient wakes up, he or she will be comfortable enough to walk about. Let me explain this as a sequence of events. So once the surgeon has seen the patient and feels that the patient requires a gallbladder removal surgery, he assesses the patient and decides, okay, fine, this patient is all right, this patient can be done, and sends to the anesthesiologist. So can all patients be done as daycare? Most of the patients can be done, except patients who have severe heart disease, severe lung problems, liver problems, kidney problems, we don't prefer to do them as daycare. Obese people, can they be done as daycare? Yes, we have done up to BMI of 45 as daycare. It depends on their effort tolerance and depends on other factors as well. Wherever possible, for whoever possible, we feel that they will be okay to have a daycare. We also look at the social aspect, that they should have someone at home to be with them. Can the elderly be done? Yes, the elderly also can have a daycare laparoscopic surgery. So once a patient comes to me for a pre-op assessment, I assess the patient, look at her bloods, her investigations, and feel if everything is normal. Then we explain to the patient that she has to be fasting for 8 hours for solid food and milk, but we allow them to have water till 3 hours before the surgery time. Then we tell them that once she has to report to the daycare 2 hours prior to the scheduled time of the surgery. Once she comes to the hospital, she will be directed to the daycare unit. He or she will be given hospital attire to wear. And once all the paper formalities are done, they will be shifted to the operation theatre where I will see them. We'll put an IV line for them, take them to the operation theatre. There will be few people around them. All are there for their well-being and to take care during the procedure. The surgeons, the anesthetists, the nurses, the OT technicians, the housekeeping people. So once we take them to the operation theatre and connect them to the monitor, we will be giving her or him a general anesthesia. Under anesthesia, we will be giving an ultrasound guided block. And once that is done, the surgeons will start the surgery. Once the surgery is over, you will wake up and then we will move you to the recovery room. The patient will be in the recovery room for an hour or so and then will be shifted back to the daycare unit. In a couple of hours, the patient will be allowed to have liquids and soft diet and also encouraged to get up, walk, and also pass urine. With this technique, most of the patients are able to get up and walk in about 3 hours, and they usually go home in about 6 hours. A pain proforma is given to them where they are advised to fill up their pain scores. They are prescribed oral analgesics to be taken at regular intervals for the next 3 or 4 days, and then they come for a follow-up at 48 hours. We also call them at 24 hours. The nurse gives a call at 24 hours after the patient goes home to just check on the patient to know how they're doing, whether they're okay or not. We also give them medicines so that they do not have any post-operative nausea and vomiting. And then when they're sent home, they just go as they came. They look just the same. Absolutely comfortable. With the tap block, we also tell them that the abdomen may feel little different. Some people say tight, some people just say different. We use the local anesthetic, so we have had patients who have given us a feedback that the abdomen feels a little different for even up to 36 hours, but they don't feel pain. So when they have no pain, when they have no nausea, when they have no vomiting, they're all very comfortable to go home and they're very confident. And a lot goes into when we communicate with them, when we tell them what to expect, when they know what to expect, then they deal with it better and then they know it's possible. I'm going to be demonstrating the bilateral dual tap block that we perform for ambulatory laparoscopic cholecystectomy. You had just seen the both sides marked, and now I'm just cleaning the abdomen. I'm using AHD to clean the abdomen. We can also use Cutacept to spray and clean the abdomen. The idea of doing a bilateral dual tab block is so that it covers all the port sites, the 4 port sites that are used while performing a laparoscopic cholecystectomy. We are going to be using a GE ultrasound machine. You can also use a sonocyte. By bilateral dual tab block, it's a combination of the classical tab and the subcostal tab. The drug used is, we use a local anesthetic, either Sensorcan 0.125% or Ropivacaine 0.2%. We do not exceed the 2 milligram per kg body weight. The probe that is used is the linear probe. The linear probe. We use a 20 gauge spinal needle. You can use an arthroscopic cover to cover the ultrasound probe, or alternatively you can also use a glove. This is how we use the arthroscopic cover. So it just goes inside and your assistant just takes the cover from you while you hold the probe. So we have used only the arthroscopy cover to cover this probe. Instead of jelly, you can use the AHD. That will help in viewing the needle. Wrong plane can cause hyperalgesia. So you lose 2 things. You are not able to give pain relief to the patient, and you also cause some pain. So we are doing the tab block now. You can see on the screen the skin and subcutaneous, the external oblique, the internal oblique, the transverse abdominis, and this is a preperitoneal layer with a peritoneal abdominal cavity moving inside. So basically this white line is where you need to come. That's the tap plane. So we need to deposit our drug there in between the internal oblique and the transverse abdominis. The linear probe has a mark in the center, so the aim should be to try to visualize the entire shaft of the needle, and you can also feel 2 pops as you go in. So once the needle is there, I usually inject little saline to see. Can you see the drug just pushing the transverse muscle down, and you can see it being deposited in the plane. Yeah. Full. You can see this whole thing is just getting pushed down, and this black see the needle, it's going from medial to lateral. You can see the entire length of the needle over there. Yeah, and now I've reached Yeah, can you see the tip of the needle there? Yeah, and the drug. The drug is getting deposited there and it's pushing the muscle down. So we are giving 20 ml of the local anesthetic at each site. You keep the ultrasound probe parallel to the costal margin. This is called the subcostal tap. The needle could come from medial to lateral or even go from lateral to medial. You just need to get it at the right place. So this side I am doing it from lateral to medial. Try to see the entire length of the needle. Can you see the needle? Okay. Then you just leave the needle there, aspirate, inject, and you see that just going in the right place. Once you made some place, you could move the needle a little more in. Then just aspirate and keep injecting. This is a volume based block, so you require a greater quantity of the local anesthetic, but what we have observed is even if it's dilute, it's still okay, it still works wonders. We also counsel the patients pre-op that their abdomen may feel different. Some people say it's tight, some people say it just feels funny. We tell them pre-op that will be because of the tap block that's given to you. Can you see the ultrasound picture now? So that's the skin subcutaneous, external oblique, internal oblique. So now again we are doing the classical tap. So now we are at the tap plane, that's the plane between the internal oblique and the transversus abdominis muscle, the dark white line. What we need to do is deposit the drug in between the internal oblique and the transversus abdominis. So I just inject a bit of saline. Yeah, when you see those drops, that dark white thing like that, sometimes a few air bubbles go in, and that's how it appears. So first we just do a little bit of hydrodissection to delineate the plane, and once we know that we are in the right plane, we go ahead and give the local anesthetic. See, you can make it out that the transversus abdominis muscle is just getting pushed down. And you can see those dark white spots, which is because of the air that was injected in the beginning. So now we've used 80 ml of local anesthetic, and the patients are usually very comfortable with this block and confident to go home once the procedure is done.
சரி ஷாம்லா மேடம் எப்படி இருக்கீங்க?
நல்லா இருக்குங்க.
நல்லா இருக்கீங்க. இப்போ ஆபரேஷன் பண்ணிட்டு வீட்டுக்கு போனீங்க. அந்த நைட் என்ன சாப்பிட்டீங்க?
நைட் இட்லி சாப்பிட்டேன்.
இட்லி.
ஜூஸ் சாப்பிட்டேன். நல்லா தூக்கம் இல்லை, ஒன்றுமே இல்லை.
எப்படி இருந்துச்சு? அப்போ நெக்ஸ்ட் டே என்ன நார்மலாக இருந்தீங்களா?
நார்மலாக காலையில் ப்ரஷ் பண்ணிவிட்டு சாப்பிட்டேன், குளிச்சுட்டேன். நான் ஹாப்பி, ஒன்றும் பெயின் இல்லாமல் இருந்துட்டேன்.
நார்மல் ருட்டீன்?
நார்மல் ருட்டீன் மாதிரி இருக்குது.
உங்களுக்கு ஆப்ரேஷன் பண்ண மாதிரி
இல்லை, பெயின் ஒன்றுமே இல்லை.
ஒன்றுமே இல்லை. வீட்டில் பாக்கி பேர் பார்த்தாங்கன்னா என்ன சொன்னாங்க?
இல்லை, இவ்வளோ ஹாப்பியாக இருக்குது, ஒன்றுமே இல்லைன்னு கேட்டாங்க. அந்த மாதிரி தான் இருக்குன்னு சொல்லிட்டேன் நான்.
ஏன்னா உங்களுக்கு முன்னாடி 3 டெலிவரிஸ் ஆயிருக்கு, அதுவும் வீட்டில் இருக்கு. இப்போ இந்த ஆப்ரேஷனுக்கு தான் ஃபர்ஸ்ட் டைம் நீங்கள் ஹாஸ்பிட்டலுக்கு வந்திருக்கீங்க.
அதே ஃபீலிங்கில் இருக்குது. நான் ஹாஸ்பிட்டலில் வர மாதிரி ஃபீலிங் அது மாதிரி இல்லை.
ஏன்னா திருப்பி வீட்டுக்கு போயிட்டீங்க அதனால
ம்
ஒரு ஹாஸ்பிட்டல்ல நம்ம பேஷண்ட் ஆயிருந்தா
அந்த ஃபீலிங்கே இல்லை, நிஜமாவே இல்லை. இதில் எதுவுமே சொல்கிறதுக்கு நிஜமாவே இல்லை.
இப்போ நீங்கள் அந்த மாத்திரை எல்லாம் சாப்பிட்டீங்க வந்தீங்க. இப்போ இது மாதிரி வேற யாராச்சும் இந்த மாதிரி வலி வந்துச்சுன்னா அவங்களுக்கு இந்த மாதிரி ஆப்ரேஷன் பண்ணணும்னா நீங்கள் அவங்களுக்கு பயம் இருக்கக்கூடாது.
கண்டிப்பாக சொல்கிறேன் நான், பயமே இல்லைன்னு சொல்லிட்டேன். என் நாத்தனாருக்கு எல்லாருக்கும் சொல்லிட்டேன் நான். ஐயோ நல்லது நல்லதுன்னு சொல்கிறாங்க. அவங்க 2 days இருந்துட்டாங்க ஹாஸ்பிட்டலில். என் நாத்தனார் பெங்களூரில்.
ஓகே
2 days இருந்து எனக்கு பெயினாக இருக்குது, நீங்கள் எப்படி இந்த மாதிரி ஹாப்பியாக இருக்குன்னு கேட்டாங்க ஃபோன்லவே. ஏன்னா
பெங்களூரில் இருக்காங்க,
இப்போ இங்கே இருக்கு.
இப்போ இங்கே இந்த ஆப்ரேஷன் பெங்களூர்ல.
ஆமாம்.
எத்தனை வருஷம் முன்னாடி?
1 year ஆயிடுச்சு, அவ்வளோதான். ஆமாம்.
அப்போதான்.
ஓகே. இல்லை நான் ஃப்ரீயாக இருக்கு, நோ ப்ராப்ளம். கொஞ்சம் கூட பெயின் இல்லை அன்றைக்கி, 2 பெயின் இல்லை எனக்கு.
உங்களுக்குவே அது ஆச்சரியமா இருக்கு.
ஆமாம், பயம் இல்லாமல் போயிடுச்சு. எப்படி இருக்குன்னு கொஞ்சம் பயமாக இருக்குது முதல்ல. இப்போ அந்த பயமே இல்லை. 10 பேருக்கு சஜஷன் பண்ணுறேன்.
நிறைய பேருக்கு இந்த மாதிரி பண்ணலாவே தெரியாது.
ஓ
அதான் மெயின். இப்போ உங்க நாத்தனாருக்குவே அவங்க
ஆமாம் 2 days.
நிறைய பேருக்கு இந்த மாதிரி பண்ணலாம், இந்த மாதிரி இருக்கு, இந்த மாதிரி ட்ரீட்மெண்ட் பண்ணனா இப்படி இருக்கும், அதுவே தெரியாது. அது அவேர்னஸ் தான் இன்க்ரீஸ் பண்ணணும்.
அதே சொல்லியிருக்காங்க. அப்போ ஆந்திராவில் கூட 3 days கண்டிப்பாக இருக்குன்னு தான் சொன்னாங்க. அப்போ நம்ம டாக்டர் வந்து இல்லை ½ டேன்னு சொல்லியிருக்காங்க. சார் அது 3 days வேணாம், ½ day எனக்கு போதும் வந்துட்டேன் நான்.
So you have seen a lady who was very apprehensive about her laparoscopic surgery and the pain and the duration of recovery thereafter, recovered so well, so quickly, and a lot of the credit goes to Dr. Pooja and her tab block. But then again, what is the surgeon's role in making this daycare laparoscopic surgery possible? Is one is a selection of patients, and one has to be careful in selecting patients and should avoid patients with major cardiac disease, severe hypothyroidism or coagulation disorders or high grade cirrhosis. Then again, even very severe cases of acute cholecystitis where the chances of conversion or more should be avoided. Then again, one has to follow a standard operative technique. In that, certain technique should be followed, so one knows as to what should be the outcome with that particular technique. Then again, one should be very careful with hemostasis. Generally, in the last about 750 cases of gallbladder surgeries we have done laparoscopically as daycare, only 2 patients we would put a drain, and the drain we removed the following day. So that goes to show that we are very, very careful with hemostasis. And then again, the thing which intrigues us, which wasn't earlier, was how is this patients recovering so very well? They don't have any visceral pain, somatic pain, etc. So the modern anesthesia has done a lot of good to it, and then of course a safe and sound technique should help. Thank you.